This is ASAP Pathway. Welcome back, everybody. Really excited for this next episode of the ASAP Pathway podcast. I'm your host today, Dr. Stacy. I know Dr. Tracy wanted to be here today, and I'll get into why, but she had a surgery so that she has to attend. So she couldn't be here. But I'm really looking forward to this conversation today with my new friend, Dr. Christian Leonhardt. Welcome.
Hi, Stacy.
I want to introduce you. This is a very abbreviated bio. You're so accomplished and doing amazing, amazing things that we're going to get into in our talk today. But for those of you who aren't familiar with Dr. Leonhardt, he is a German dentist based in Augsburg, known for his interdisciplinary, digitally integrated, and airway-focused approach to modern dentistry. He's the founder and clinical director of Dentists at Perlock. As I say, Perlock?
Perfect.
Okay. Where he and his team focus on comprehensive functional anesthetic rehabilitation. With advanced clinical training in prosthodontics, orthodontics, periodontics, and endodontics, he's a certified aesthetic specialist by the DGAZ and a mentor at the Coy Center in Seattle, which is where he's doing this podcast from today. He holds 2 Master of Science degrees in orthodontics and has completed extensive airway-focused training under thought leaders such as Dr. Zaghi and Dr. Robley. He lectures internationally, including at the American Academy of Restorative Dentistry, the Coy Symposium, and various global platforms in digital and airway dentistry. Dr. Leonhardt is the founder of Quintessence Study Club and academic director of the interdisciplinary curriculum, the Art of Digital Dentistry. In 4 weeks, he's going to be teaching a dedicated course at the Coy Center. We'll talk about that in a minute, furthering his commitment to advancing interdisciplinary education. Outside of dentistry, he's a dedicated family man with 3 sons between the ages of 7 and 12. And in his free time, he enjoys running marathons together with his wife. I love it. Welcome, welcome. Thank you so much.
Yeah, thank you for the invitation.
First of all, you just have such a unique background. We were talking about your 2, we were getting into this before the podcast, and you said, I can explain. Because I said, what do you do more of? Orthodontics, restorative? How would you describe yourself? Because you have 2 masters in orthodontics, but you have all this extensive training. You're getting into digital dentistry, restorative, airway focused, airway comprehensive dentistry. So if you could, how would I describe you to somebody? What's your journey?
So, to start with, I always have to think of the Coy Symposium for 5 years ago, when Tracy told about her airway journey. And so I had my own journey. When I finished dental school, my first goal was to maintain teeth. So I realized I had to do my endo specialization. I had to go very deep to maintain teeth. After doing that, I realized, okay, endo is not everything. I want to go more into the perio part, even to maintain the soft tissue, the bone, and to maintain teeth again. And then I realized, okay, I had to learn the functional parts and the restorative parts. So I went into the prosto part, doing every curriculum I could find. And in the end, I had more questions than answers because there was no red line in all those curriculums. All the speakers, all the lectures had a special topic, but nothing was connected. And then I got a recommendation to go to the Coy Center, where I got my new boxes, my new structure and the protocols. So this was the entry of my full comprehensive treatment planning. And this is how I think this is very important to have a protocol for every treatment step. Even if you have the first appointment or where you are, it's important for you and the team. And after realizing that, and I had big cases, I saw, okay, there's a need for ortho. And to think about ortho, it's what I was, I learned it in the dental school, but it was a total different thing what I needed. So first of all, I prepared all my cases as good as I can and sent them out to the orthodontists. And so often I get some cases back where I think, okay, there are two ways to think about a case, the orthodontist lens and the general dentist lens. And so I was so often disappointed that I said, okay, I have to learn this. And I do not only have to learn the biomechanics and the tools, I even have to understand new comprehensive thinking of ortho. And so this was the reason why I went into these different ortho courses, learning biomechanics, learning the techniques, but even learning the philosophy. And what I saw then is that there was a traditional philosophy of ortho, where we have some dogmatic thoughts that every case should end in class 1, the angulation of teeth, the intermolar distance, the intercanine distance. And so I was thinking from an orthodontist perspective, okay, but from a prosthodontist perspective, a total different thing. And then I got to know very, very good people, smart people like Tracy, like Steve Lamberg, and they showed me, hey, Christian, have you ever thought even about the health of your patients? And so this was the beginning. I was thinking about what I did. And then I had one case, I've been treating with aligners. He had spacing between the teeth in the front and was an aesthetic indication. And I did it to that time as good as I can. So I retracted all the teeth, and suddenly the patient had problems. Problems with speaking, problems with swallowing, problems in the night with the low tongue posture. He started to snore, his wife was claiming. And with all the knowledge I got to this time, I said, okay, I have to check it. And so I did a polygraphy with the watch pad, and I saw that he had a high AHI. And I thought, okay, what I was been trained by John Coyce is that we always have to think about when there's a treatment planning. We have to think about two things, the risk actually, and the prognosis in the future. What's going on with this patient? And I said, okay, I hired the risk for this patient because I retracted, I took the space for the tongue, I took everything out. So I said, okay, we had to redo the treatment. And I brought all the teeth out again, said to the patient, we have to treat it with restorative treatment, and the patient agreed. And after the ortho, when I had all the teeth out again, with the spacing in the right position, where we want to have it for the future restorative outcome, it went better. And so this was my eye-opener case for the airway. And suddenly I realized, okay, there's something more than just aesthetics or dentofacial, the function, the perio, and the biomechanics. It's something what is more important than the way we think about teeth. Because in the end, what is more important? The health of the teeth or the health of our patient? And so I started taking my airway journey, going into the courses from Airway Collaborative, from your courses, having a lot of good chats with Steve Lamberg. We invited him to Germany, and was, always you meet people who are so inspiring, and you think about what's going on with the traditional ortho world. Some people now realized that this paradigm shift is still going on. Some people live in the old thinking, what is really okay for them, because first of all, you cannot see it until you don't know it, or you cannot know it until you don't understand it. But what my task is to bring that knowledge even to the people. And then you meet such great people. And one game changer in my way of thinking was then the part of the growth and development, which Stephen Becker from London opened
Yes.
my eyes. Yeah, you had the podcast with him.
Yes, I love
And
Stefan
it
Becker.
was, it was like, wow. So, because we often treat the how, so the tools, the biomechanics, but we did not think about the why. So the why is based in the growth and development and the adaptation and compensation of the patients. So this is something what we can say, that we are just not longer just saving teeth, we are saving the patient's growth and development. And what John Coyce said is that we try to avoid the crippled adult. So this is something what I realized. And so it's not that we are going totally airway directed in every case, but we go with airway awareness into case. So we say, okay, is this case an airway positive case, or is this case an airway negative case? And airway positive means we have to treat it, otherwise it's not good. And it's our task to give the patient all the information what's necessary. And what we know from the comprehensive approach of our patients is that they have to know their numbers, and not only that AHI is about sleeping, but airway is so much more. It's about the posture, it's about positioning, it's about everything. And structure, function, behavior is a big thing. So this was my airway journey, and now we are here, and I'm very excited to talk with you.
Well, I I think it's so interesting on this whole journey. Like even with our ASAP members or people like you, people like Stefan, we all started with an aha moment. And you find yourself uh getting in the trenches and you almost, we always affectionately call it the rabbit hole. You start learning one thing and you're like, oh, wait, but I have to learn about this, or I have to learn, or at least find other people to, collaborate with and refer to. And then you find yourself sometimes the best way to learn is almost to put yourself in a teaching aspect. Like, what you're doing or what we're doing at ASAP. It's like we selfishly put this together. Like, this is what we wish we would have had. This is what we wish was available to us. And then you still continue the journey just because you're in this educational, now you're teaching. You had your journey, you meet your people, you find your community, and now you feel this calling, this, you know, um, need to educate other people and to enlighten other people on the journey. But we're still learning, we're
Yeah,
all still learning from each other and together. I say all the time, I love doing these podcasts because I learned something. I'm always taking notes during the podcast, and I go back to my office or I go back to Tracy and Michelle. I'm like, we need to start doing this now. Um, and so it's a humbling, fun journey, this life of ours. Um, so you kind of we're talking about this turning point, and it made you rethink everything. But let's address, that to change. I mean, obviously, you've changed a lot. How you practice now is not the way you were practicing 2 years ago, 5 years ago.
no, no. So, it's a learning process and it takes time. So to start with it, it takes a long time to learn all the things, what's necessary to understand, even only the structural parts. What assessment is necessary to inform your patient about that, what's going on, how much compensation and adaptation was going on in his mouth, what is a, a real achievable goal for him in this situation, what is necessary to treat the patient to get to this point, even from when we go into ortho, from the dental movement part or dental alveolar remodeling, or even from the skeletal part. And so um, this is now the turning point where it's always the same. You have to come out of your comfort zone.
Yes.
And it's not an easy part, because you have to change a lot, not only for you, not only for your patient, even you have to educate your whole staff in your practice, because they have to think about all those too, because patients come for the cleaning procedures, the hygiene, and ask them what did he say, and they have to give the information even in the same level than you, or in the same perspective. So this changed a lot. And otherwise, you know, the way we assess now our patient is not faster, it's even more, and it takes more time.
Yeah.
But in the end, you have so much more information of your patient, and you can be more predictable even for the outcome. Because what I already created when I did not know everything from my patient is that I did not know something about tongue posture. I did not know something about the mouth breathing. So I predicted to the patient that we have a stable situation. But the problem is that it is never stable in such a situation. There's always remodeling. And so I don't want to have the relapse. So this is something what we discuss with the patient. Patient have to train. And even the collaboration in the multidisciplinary part with ENTs, speech therapists, body workers, all the people around help us to achieve one goal. And what I call to Renata is that we try to achieve, or we want to have a big picture of the patient. And so we define the frame with our assessment and diagnosis, and it depends on the people who work in this network or team, how the picture looks like. And so it is a lot of training, it's a lot of skills. And so for me, it was the game changer in a treatment procedure. What do we assess first? What do we treat first? And when do we do the traditional parts of dentistry? So when I started ortho, I learned to make diagnosis, what is really not smart, clever. I learned to make diagnosis in between 5 to 10 seconds, looking at the teeth, looking at an intraoral scan, and say, okay, we have to treat like this, this, this. Then, with all the implementation of COIS principles here, we know how to implement the remounting situation. So, what is the real bite of this patient? Where do we want to go? But now, from an airway perspective, the teeth are the last thing what we are looking for. First, we're looking at the posture, we're looking at the face, we're looking at the myofunctional part, we're looking at the tongue positioning, we're looking at the nasal breathing, looking at the mouth closure, swallowing patterns. And the last thing is the teeth. So it's like a vice versa planning phase. And so it's even about having more technical parts in your practice. We need a photo studio to do good photos of the patients. We need a traditional assessment, intraorally, extraorally. We need a sleep assessment. So a lot of things to do, and patients do react crazy, because I had not one patient in the practice who was leaving the practice because we did more for him.
That is
What's the
exactly what I want to get to.
Yeah, and
You're
it's it, it's so and it's so interesting how patients react, because they said nobody ever was asking me this. Nobody ever was taking care like that for me. I had never such a good conversation with a doctor, even with my physician.
right.
And nobody was able to see what I was thinking, what is the problem. So what we learned here is that the patient fill out their medical history and dental history in a very perfect way, without knowing exactly the diagnosis, but they exactly know what's going on with them and what's wrong with them, but they could not define it. In the way we're doing the diagnosis, we're having the discussion, we're doing the sleep assessment, we're doing all of these things, people suddenly understand what the real problem is. And they come and say, could you fix it? So the cool thing is, in that moment, you're going out of that position where you are a hitman and you say, patient, you have this, this, this. So they come to you and say, I have a problem, could you fix it?
Mhm.
And you say, depends what it is, but on a risk assessment, like a bell curve, we can go to a lower risk for you. I cannot predict or I cannot promise
Right.
that we will fix it 100%, but I can predict that we will be better in the end.
I love that because, a lot of times we get into, at least when I started my journey, and the awareness of how the dental profession, the orthodontic profession, had such a seat at the table. At first, it was like, okay, my expander's going to fix everything. And you realize and you get humbled really quick when you realize it helps, it has a place, it is needed, but to expect complete resolution of everything because it's so multifaceted. So you do
Yes.
learn that there's different facets. But I love how you say, and I've been implementing this very language in my practice recently, just discussing risk factors. Risk factors, what is in the patient's control, what's out of the patient's control, how can we lower risk factors, remove obstacles, at least get things out of your way to be your healthiest self. And we definitely have a seat at the table and we have a role with patients in removing those risk factors or lowering the risk factors. But I wanted to back up a little bit about your discussion. And you so beautifully said this. You take actually more time with the patients. You haven't lost patients because you're caring more. You haven't lost patients because you're being more thorough. You haven't, but I'm going to speak. I'm probably ask a question that the person listening right now that is teetering on this, they're not sure if they want to take classes because once you open the can of worms, you can't put it back in. So for you to change the model of your practice, how do you speak to the practitioner? What do you say to them when they're nervous about, you said, oh, now we got to take pictures. Now we've got to take more time. We're going to have to change the schedule. Our new patient exams are longer. That makes some doctors nervous. It makes their team nervous. How do you speak to that doctor about the anxiousness of changing the model? Because it is a big deal and it is scary. Um, but it's imperative to do so to help more patients. So you did all those things because you couldn't unsee what you had seen already. So
That's right.
how do you maybe how do you have the conversation with your team? Like, hey, I'm getting ready to go take a course. I'm going to a course at Coice. And I'm going to come back and we're going to make some changes. You got to include your team in this.
You know, when I say I'm going to courses, I see those eyeballs rolling because
Yes.
they exactly know what's going on when I'm back. It's always the
They
same.
know, oh, here he comes. Here we go.
So,
We got to do all these new things now.
so, you know, I I need harmony in the team, and you need the people around you because you're spending more time in the practice, or I do when I'm thinking about how much time I spend in my practice. I'm spending more time in the practice than with my family. So I think, it depends with who you are and who the people are really in the heart. And I needed that we are on the same level. It is always combined with some discussions because even they have to come out of their comfort zone. They have to understand what's really going on. And so, you know, the, the girls in my practice or the staff members are excited about that, what they do, because now they see that the people have emotions to have this treatment fulfilled. So people come into the practice, and this week it was one example for that. There's a patient. She's very anxious. She's she's a new patient. It was a new patient in the practice. She went through this whole assessment, the diagnosis. She was very narrow. She was a mouth breathing, or she is a mouth breathing patient. She has an intermolar width of 27 millimeters, so very narrow. Periodontal problems, a lot of tip teeth, recessions, all of that. And went from doctor to doctor, tried to find someone who can help her. And even specialists showed her a symptomatic treatment, so recession covering. But if you don't treat the cause and you only treat the symptom, you can wait until the symptom comes back. So I was telling that all to her, and now she's ready for MAPI. We did the suture opening. We did a dome therapy on her. So she was coming to the practice and said, "Now I'm ready. I want to start with that." And that's something what changed the people's mindset. They see the problem, they understand it,
Yeah.
and in the way we start with the treatment, they suddenly realize it's now possible to breathe through the nose. It's suddenly possible that they having a better tongue positioning. So could you imagine? I could not imagine this before, because as a dentist, I was never thinking about nasal breathing, because people come into my practice and said, I cannot breathe through my nose. And 10 years ago, I said, oh, that's bad for you. I'm sorry. But now I understand there's a reason for that. And often it's an ENT problem, but often there is a transversal problem, and we can help it with them. And we have the Hagen-Poiseuille rule. When we open the floor of the nasal, we have much more volume to have this limitation of this breathing process through the nose. And this flow limitation is the biggest problem. And the moment when patients come in week 4 to 8 after starting with MAPI, and they say, I had the first night when I could breathe through my nose. And they hug you for the things that you make nasal breathing possible. This is something really cool, because then the quality of life is getting higher and higher. And so I did not think about, when I was sick and I have congestion in my nose. This was this awful nights, but this was their state of lifetime. And so this is one topic. What happened this week? You get hugs from your patient who were anxious and say, I'm so happy that I did this treatment, and it's a long journey for all the next steps, doing then afterwards the alignment, doing afterwards the restorative treatment. It's a long journey for them. I totally agree, but you help them so much.
Yes, and you cannot do it. And I tell my team this, and maybe I don't tell them enough. I try to work on telling them more, but we can take all the classes, coursework we want, but if the team is not on board as well, you can't do what you do.
No,
So it is
no.
a team effort. And what I have found, and sure, I have had even I've had people interview at my office, and they're like, "Oh, you guys do a lot of stuff here. I don't know that I." Well, you're not a fit, and that's okay. But
Mhm.
most people love to be part of something greater. And when they see that change in that person's quality of life and they get to be a part of that, it's very rewarding. For a person listening right now, oh, I'm afraid my team won't, bring them with you as much as you can to courses. Let them see, let them get excited too, because once they experience it, they're all in. usually they're all in and they get the hugs too, like you said. Stanley Liu said something. He was on a podcast recently with us, and he was saying, who can really affect the nasal breathing of a small child? It's really beyond allergy intervention,
Yeah,
beyond that, the actual structure of the nose, that's done by the dentist or orthodontist that is doing orthopedics. You are actually increasing that nasal patency for that child where nobody else can. And
yeah.
it's
And
life
and
changing.
and Stacy, do you know what? We had we even have team members who bring their whole family because they see now what's wrong.
Yeah.
And for the kids, I do not really know how it is in different countries, but in Germany we have certain rules from the social system when it's the right time to treat a patient from an orthodontic perspective. And often we have to wait until the full dentition is there. So then the kids are 10, 11, 12 or older. And so we all know that the mid phase is done. So we have no chance for the mid phase. And what we now know is that the, the whole dental planning or the whole dental structure planning is something where we don't want to be reactive. We have to be proactive in such a moment when we realize that the first symptoms come. We have to think about if we can make it better. So this is something what I even told to my staff members. I don't want to wait until the situation gets worse. I have to I am responsible for my patients, and that's something what I am as a general dentist, different to a specialist who sees a patient for a certain time. I want to see my patients in 10, 20, 30 years. And so I don't want to regret or apologize that I saw the symptoms and I did not treat it. So what could I expect? So from a functional perspective, we have the literature. And even from the airway perspective, we have the literature too. But, you know, then people come and say, okay, there's no evidence or there's lack of evidence. Come on, the whole dentistry has lack of evidence. So we
Yes.
have to think about how long should we wait? And in reality, I always tell the parents, go in as soon as possible, because then the treatment is could be done in a very minimal invasive way or is not done in a long time. So this is something what my staff members already accept, and it works perfectly.
How are you navigating? I've talked to Stefan Decker. We've had him on the podcast because he has the same similar aspects with the social medicine aspect of you don't do anything till all the dentition's in. Well, they're already done. They're done growing usually by that point with the mid.
Yes,
So how do you navigate those waters? Because I mean, we have ASAP members that are in Canada with some obstacles as well. Even in the United States, where we have private systems, but still there's this community backlash and opposition from other colleagues. But when it's really in a social, setting with healthcare, universal healthcare kind of situation, like how do you navigate those waters?
it's not a must that you treat it like it is given by the social system. You can decide, and you have to educate the parents, you have to educate the patients, and so it's their choice. And in the end, it's more a private system. That's the other system than the social system. Um, Nobody of the parents don't want to help the kids. So we don't have to go very deep into that with the parents. They understand it immediately because the only thing what they need is the right assessment, the pictures, and they suddenly accept what or agree to that what we tell them. And so I think this is now a new chapter of informational process to the patients. And I think this is the only way to be honest to all your patients, to tell what's really going on. That's what they deserve,
Yes.
and nothing more. And when you want to work interdisciplinary or multidisciplinary, we need even the diagnosis from a myofunctional therapist. And so everything has to be combined, and then we find the right treatment protocol. Because, for example, we have problems because sometimes people start to learn the airway, then they think snoring, and then they already combine snoring with the treatment. But snoring is just a symptom. And snoring, there's always a why behind.
Yeah.
So we have to accept going a step backward, doing a bigger assessment, taking the right diagnosis. Then we have the risk management, what to do, what can we do, what not. Then the treatment options, and then we go into action, the execution. And so this is now a next chapter for the whole system in my practice, even with all the colleagues, all the physicians, ENTs around it, to accept that we find the best treatment outcome for the patient. It's like a backward planning. Where do we want to go? We define what is achievable, and then we decide what to do with the patient. And so this is the way we communicate it.
It's like you have to reverse engineer a little bit.
Yeah,
Oh, you kind of
yeah.
have to reverse engineer. And, you know, I think what is beautiful about, being, as Steve Carsonson would say, a primary care dentist, um, is we are really walking the full spectrum of life with our patients. It's not like we're doing a specific specialty and they're gone and we never see them again, like in other specialties. The primary care dentist is, I mean, we're seeing the mom while she's pregnant. We're guiding mom on her sleep and airway health while baby's in mama, you know, and then baby's born and baby comes to us. And then so we've been taking care of that baby since before baby was born. And then we're walking the journey with that baby and we're seeing its journey and trajectory. So I think it's a unique perspective for the primary care dentist, um, who, like in the United States, the American Association of Orthodontists, they recommend a screening by age 7. But when we're seeing a kiddo who is 3 and they're already chapped lips and we see that they have a dental malocclusion, no spacing between the baby teeth coming in, and we're going, oh, we're not waiting till 7 to intervene. So we have
They never grow out of that problem. They
never,
always grow in that problem.
they grow into the problem. And
Mm.
I started my journey with adult dental sleep medicine. And so, attending the AADSM, American Association of Dental Sleep Medicine, you know, uh, it's been definitely a heavily adult airway management bend, more of like holding the jaw so it doesn't fall back. And um, then it was like about sleep apnea in children. And it's not even just sleep apnea. I mean, very few children have, which is awful that they do have that, and we want to help those children, but it starts before that. It
True.
creeps in. It's a very uh sinister, kind of, subtle start. It can be mouth breathing and then snoring and so you have to start asking these questions and changing your health history a bit so that you can catch the changes because they aren't so sometimes frank and obvious you can catch these things when they're just starting and make such a difference in a kid's life. Such a difference. And the parents are so grateful, right? Christian, I mean, they're like, nobody's ever connected ADHD or ADD to my child's sleep. Nobody's ever asked me if my child was bedwetting or why their lips are chapped all the time.
Yeah.
Um, so it does.
Or even the adults, you know,
Yes.
when you see them and high blood pressure. Steve Lamberg all described this in his book, all the comorbidities who are connected from a scientific point of view. And this is crazy when you think about when you have stress at night, this is the moment your body should recover. And your body could not recover because as soon as they go into deep sleep or the REM phase, and the tone gets low because of the why behind the structural parts, the functional parts, the behavioral parts. The body gets stressed and they will grow into bigger health problems.
Yeah.
So I think this is something what we can now change, and this is hopefully my topic here to in the next years, and I try to bring more structure in that part. One thing for adults is that I created a risk assessment bell curve for airway from the structure, function, behavior part, so that we see, okay, where we are on the green part of the risk curve, where we are in the yellow part of the risk curve, and then in the red part. So everything now is visible. And so people is for most of them, it's very important to put them like, yeah, like a green, yellow, or red risk. And then you know exactly if there's a need for treatment or if you have to be aware or if they are an airway negative patient. So
Sure.
this is something what helps me a lot. And then even for the treatment options, nobody ever told me before that I cannot do everything with aligners. So only the structural expansion by dental alveolar parts does not help the patients. Often we have to go to the midline, and often it helps us so much more because then we could readapt or recompensate all those adaptation and compensation on the outside for the teeth. Because when you see this collapse from the muscles on the buccal side and the teeth are collapsed to the oral side, the roots get out. And if you have a thin phenotype and the roots come out of the bone, what's going on? You have recession, and then you try to help the patients with symptomatic treatment. But in the end, you always have to bring the teeth back in the bone, which makes the intermolar or intercanine distance even less. But when you work from the inside, even from the skeletal expansion, you can work so much more. And this is something where we have to merge both worlds of dentistry. That's what I mean from the prosthodontist or from the general dentist side and the lens from the orthodontist together in one treatment planning. So even if not everybody is able to treat patients orthodontically, someone has to be the tamer in the ring, like an orchestra. It's not important that you have the 21st violin, but someone has to be, yeah, someone has to be responsible for the whole team. And so this is something what we try to educate people. So I think this is now the next chapter of dentistry.
I believe so. I believe so. And I mean, you're just seeing uh, these conversations are happening more and more. 10 years ago, I was beating this drum in town and nobody wanted anything to do with it. 5 years ago, whispers were starting. And now there's so many practitioners open to, hey, there is something to this. And bigger picture, seeing the patient as a whole person. I also think patients with social media and they want, they're more about being having their autonomy and educating themselves. And I also think, there are people listening, there's a person listening right now that they know something is off. They know there's more to it than is being told to them, and they're on their own journey and they're going to demand the care for themselves. And they're looking for the provider that's going to listen to them. So I do think there is a drive for this kind of treatment, that patients are starting to
So,
demand this kind of treatment. And the more we educate and more you educate, um, I think more patients are going to become more knowledgeable about it and demand it. I mean, the pharmaceutical companies figured that out years ago. Go to the patients, tell the patients, do you have A, B, C, D? Well, you might benefit from this. Ask your doctor if you're a candidate. So I think going to the patients and educating them that maybe it'll increase even the drive with the practitioners wanting to learn this. So you're right now you're in Seattle and you're
sure.
teaching a course with the COIS Symposium. What what are you teaching?
So it's called the dental lifespan or expansion of dental lifespan of our patient. And it's that what I mean. It's looking through both lenses, merging both lenses, taking in growth and development, taking whole action of this lifespan of patients, risk management, prognosis, and then giving all the dentists here a real treatment planning concept for every step what they do from assessment, from the diagnosis to the risk management, and then for the execution. So we have a 5 days course here then in 3.5 weeks. We go through every part. We learn from all the principles what we already know from dentistry, and we connect them to the ortho world, and then we bring all the airway principles in. So it's an easy step-by-step tool. And we don't, Stefan and I don't want to come as astronauts so that people look, okay, they are crazy what they do. So often you see such cases in presentations or lectures where I think, okay, this is really cool, but I cannot do it. What we really want to do here is we want to help the hiker come up the mountain.
Hmm.
So we take them going step by step through every part, help them with their cases. We discuss every step, make it visible. It's a very clinical course where we help people on a theoretical side and give them even the clinical perspective how to do it in our cases. So yeah, I think it's gonna be a really cool course. And I
Now
think
this is in 3.5 weeks, the
this
one,
is in 3.5 weeks.
and
Yes.
right now it's currently sold out. Is that
It's
correct?
That's true. Even the second course.
Oh my
But
goodness.
I think we will open another courses in North America, maybe in Canada, and we want to do one course and Stefan's Academy in London, and I think it will grow. Yes, it will be
Oh,
cool.
yes, it will. It will definitely grow.
Yeah.
I'm gonna put, and I'll get all the links from you to put in the podcast as well. But something else that you're doing, which is so amazing that we were talking about before we went live, was this Vienna Airway Conference. Tell me
Yes.
more about the Vienna, and like the last one you had about 18 different nations represented
Mhm.
there.
Mhm.
Was that its first year?
Yeah, it was the first year, over 105 or 110 participants. It was a huge success. So the idea came when we had a special treatment of a patient in Austria together with two colleagues there. We did a new technique. It's called the guided dome technique, where we want for MAPI or MASP expansion with more than 7 millimeters. We went to, I think, 10 to 11. And it's with cutting from the outside of the buccal bone, from the inside of the sinus. It's piezo technique. But then we said, okay, we have all the same problems. We do not have a network. We have to build it because you don't find it. It's up to us. And we said, okay, when we have a network, how do we educate them? Then we come back to that we do locally. And then we said, hey, it would be really cool to organize a congress, the first interdisciplinary congress, where we have dentists, orthodontists, pediatrics, ENTs, speech therapy, all the people who are necessary to treat a patient in this special way. So we decided to go for it in October last year. Stanley was coming, Renata was coming, good speakers from all over Europe were coming, and we had 2 days. And you know, the atmosphere, it was mind blowing.
Mm.
It was, you know those lectures or those meetings, we say, hey, it was okay, it was cool, I learned a lot, but in this way you felt connected. And this was, yeah, even as an organizer or the founder, for me it was like being part of that. And we said, even if we do not earn any dollar or euro with that, in the end we paid more than we got. But this was not the topic to make money from that. It was like our goal was to build a bigger network, a network who has the same education or is on the same level of thinking. And we want to have people who speak to each other and who are able to define a certain quality level where they want to achieve the treatment. And so we define always a red line through all the speakers that everybody is able to understand what's really necessary, what happened from the literature. And yeah, and this year we have Patrick McKeown. We have good, really, really worldwide known orthodontists who are speaking, ENTs. And I hope that it will be a success too.
Oh, it will.
The website is airwaycongress.com. And it's
I'll
in
say
Vienna.
that again. It was
It's
airwaycongress.com.
airwaycongress.com,
Okay.
and it's in the old Central Bank of Vienna. This is an amazing building. All the Americans who came said, "Where are we? Where are we in the sky, or where are we here?" It's so beautiful, yeah. And really, it's I think, yeah, it it's it's it's
It
it's
sounds like a
yeah, yeah,
life-changing, career-changing,
yeah, yeah.
mindset-changing
And
event.
we have so positive feedback from all the disciplines, and even from people from university came and said, I never had this experience on this high level of scientific based knowledge. And we don't want to have, even if we have those emotions there, but it's so important when you talk about airway to bring all the scientific information into it,
Yeah.
so that we bring all the evidence, so that we talk about where are the goals in the future, where do we go, what are our experience from the past, does it work, does it not work, this is even evidence. So it's on a level, very low level, but then Stanley was coming and telling us a lot of great things from Stanford, and yeah, it was a nice time.
I love it. Well, I'm excited to personally go myself. That sounds,
Yeah,
it sounds like I just love being in a room with like-minded people. The older I get, I just feel like I want to be in places that I feel feed me energetically,
yeah,
not take away, but feed me and really put my energy into that and be with other like-minded people that are, I learn from, I connect with, and it just adds so much to your life personally and professionally. So it sounds like one of those events where you walk away thinking, what an amazing time,
yeah.
Sounds
In Germany, we have a saying, it's like a light machine. You put energy in, but you get more energy out.
I
And
love that.
this is
Well,
something,
yeah,
yeah,
say it again. It's like a light machine.
it's like a light machine. You put some energy in, but you get more energy out.
Okay, well, I'm going to Germany in a few weeks. How do you say that in German? Say that in German. It's a light machine.
It's eine Lichtmaschine. And
Okay.
I can tell you more about it because we have a lot of sayings for energy development and personally integration.
I love
It's
it. Well,
yeah.
I told you that I'm going to be hitting you up on some Munich Munich ideas, and my kids are so excited. My kids and I are going, but yeah, I think it's what I love about this too, though. This is a movement that is needed worldwide. And I love that, you're coming to the US, you're learning, you're taking information back to Germany, you're bringing information to us. And this is definitely needed. And I am excited to see what happens. Like you said, this is the future. In the next 5 to 10 years, it'll be so interesting what we're talking about,
Yeah.
you
And
know.
we now live in a generation of dentists, in my experience, where it's not more necessary to build churches. The one is in that church, the other one is in that church. It's all about collaboration and it's all
Yeah.
about having intense discussions. It's not about fighting, it's about having the discussion. It's about taking people out of their comfort zone
Yeah.
and bringing them to another level of the way they think. And so
I do
this
think
is,
this new generation of dentists are going to take us there. I do think they think differently and they are more willing, I think, to cross aisles
yeah,
that the generation of dentists before, like you said, the churches, the silos,
uh,
everybody was stuck in their
yeah,
dogma
yeah.
and you would die on that hill and you weren't
Defending it.
yeah, defending it. And now we are like, yeah, that doesn't really work so well. We're going to help more patients. We're going to help people in general if we all start collaborating more and communicating more.
Yeah,
Um, so I'm definitely going to put all the information we talked about, airwaycongress.com in Vienna. I'm so excited. The COIS courses, I know they're sold out, but we'll put some information because you're going to create more. I think we're going to see more of a demand for that. Um, but I also, at the end of every podcast, I like to just ask 3 questions that really are random and they don't have anything to do with much of anything other than we just kind of get to know you a little bit more. So, are you ready for my
ready.
question? Oh, this one will be interesting. Okay, number one, if you were a kitchen appliance, which one would you be and why?
Oh wow. Oh wow. Um,
Would you
I
be?
would be I would be the universal knife. You can cut everything with me.
Oh, I like it. The universal knife. That is so good. Oh, I really wish I had one of those actually. Where is your favorite place to vacation?
Iceland.
I've heard that is gorgeous.
Oh. When we have this symposium here, I'm that one who is leaving 1 hour earlier. Nobody has to know it, because then I can catch the plane, fly overnight into Iceland, having the whole Sunday only for me.
Oh,
I'm thinking of my wife, but having
you're
the whole
thinking of her,
Sunday,
but she's
then
not
I'm
with you.
it's very close. Everything is very close there. And then I take the rental car, first go to the volcano, run around the volcano, then going into Reykjavik, having a coffee there, and then one tip is going into the Sky Lagoon. It's a very modern lagoon directly at the ocean, and then going back, flying to Germany, and then Monday morning, 7 a.m., I land in Munich, and then 8:30, I'm at the chair and I can work. So this was Iceland is blows my
I've
mind.
heard it is one of the most beautiful places on earth.
Yeah, yeah,
And
it is.
now,
For
If
people who love to be at the beach, it's not the right place. For people who love to be in contact to nature, oh,
Mhm.
it's beautiful.
That's my jam. Well, now at the Vienna conference, if I see you, I'm gonna be looking for you. You're going to be slipping out an hour early so you can head to Iceland. I love this. Okay, last one. This one's different. I've never asked anybody this. Um, if you could start a rumor about yourself, what would it be?
Oh, a rumor.
Like, hey, did you hear that about Christian Leonhardt? What would you start about yourself?
Oh.
I'd make it a good one.
If he's telling you that he can sleep very well, it doesn't. No, better. I know a better one. If he's don't talk about life-work balance, because if you don't love your job, it doesn't make sense. So, I do not think about life-work balance because when I wake up, I think of work because it makes so much fun. When I go to bed, I think of how we can do it. And even if I watch a movie, I'm looking for things what we can do better. So I'm not good in rumors, but
You're
I
like,
think
well,
this is
hey,
something like,
yeah. Did you hear that rumor about Christian Leonhardt? He has zero work-life balance because all he does is think about
yeah,
work.
yeah, okay. Thank you.
Oh, I love it. But your work is a passion of yours. So work doesn't feel like work when you really, really
No,
love it, right?
no, no, it
Yeah.
doesn't.
Well, thank you for being here. We'll have to have you on. There's so much to talk about. We'll do a part two someday, catch up and see what you're doing next. And for those that want to know what's going on more with ASAP, we have a lot of stuff, exciting stuff with our immersion program. You can do everything from home in your pajamas, in your sweatpants from your couch, and we have a newsletter you can sign up for. But thank you, everybody, for joining us. Thank you, Christian.
Thank you, Stacy.
We'll see you all next time.
See you.
Bye.
Bye.
This podcast would not be possible without the inspiration of my dad, Dan Becker, and creative direction and editing from the talented Jason Becker, Benjamin, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice to replace your healthcare provider's diagnosis or recommendations.